The introduction of today's speaker, Professor Glenda Gray. She is an NRF-A1 rated scientist. She is CEO and president of the South African Medical Research Council, and she is a qualified pediatrician and co-founder of the internationally recognized perinatal HIV research unit in Soweto, South Africa. Prior to her appointment at the South African Medical Research Council, she was the executive director of the perinatal HIV research unit, an affiliate of Wits University. Glenda's global profile includes a role as co-PI in the HIV Vaccine Trials Network, an international collaboration for the development of HIV/AIDS prevention vaccines. As the COVID-19 pandemic developed, she was among the first to lead public discourse on the issue and to move quickly to establish COVID-19 vaccine trials in South Africa, utilizing the experience and network developed over the years for the HIV vaccine work. Glenda served as a protocol co-chair of the multi-country ensemble study investigating the single-dose vaccine as an emergency response intervention. When South Africa's national vaccine rollout faltered, her international stature enabled her to negotiate a donation of 500,000 doses of the vaccine before any emergency use authorization was available and conduct a phase 3B open label study in healthcare workers called the Sisonko study. She received a number of awards, including South Africa's highest honor, the Order of the Mapungubwe, for her pioneering research on the perinatal mother-to-child transfer of HIV. Other prestigious accolades include the Nelson Mandela Health and Human Rights Award for significant contributions in the field of mother-to-child transmission of HIV. She was selected as one of the Times 100 most influential people in the world, the Forbes top 550 women in Africa, and honorary degrees from a number of universities, including the Simon Fraser University, Stellenbosch University, and Rhodes University. She was awarded the 2020 Herschel Medal for her distinguished multidisciplinary contributions to the furtherance of science. Then she is a member of the National Academy of Medicine, the Academy of Science of South Africa, the African Academy of Science, and the World Academy of Science. And she is a fellow of the American Academy of Microbiology. Today, she will give a talk on a topic that's very close to everybody's daily life, and that is about COVID. And she will tell us what the current status is and the outlook on where we are going with COVID. Glenda, the floor is yours.
Thank you very much for that. Hope you can all hear me. I'm going to share my screen. I can find it. Are you able to see that?
It's working on it. Yes, perfect. Okay. Thanks.
Thank you very much for asking me to give this talk. And I'm going to look at the pandemic and look at the past, the present, and the future. And I think as we reach the state where we are now and look back on the last 3 years, we can see it as similar to the Charles Dickens A Tale of Two Cities, where we saw the best and the worst of times, age of wisdom, age of foolishness, the epoch of belief, and the epoch of incredulity. It also was the season of light, the season of darkness. It was the spring of hope. It was the winter of despair. And I think that epitomizes the kind of feelings that we had as we navigated our lives during the pandemic. I'm having problems moving my, there we are. So I'm going to, in this talk, acknowledge that COVID-19 was our first great pandemic of the 21st century. And as I said before, we'll reflect on both the past, present, and the future. I'm going to look at death, the devastation of mitigation strategies at a global and local level, and then bring in hope in the form of a vaccine, the present day where we find ourselves, and a discussion about is there an end game, and when and will that ever happen? So just to go acknowledge that a tremendous amount of people at a global level died due to COVID, and the confirmed cases of death were much less than when we look at excess death estimates. And yeah, you can see that if we look at a central excess death estimate. At a global level, we estimate that over 20 million people probably died due to COVID-19. And however, we only have over 5 million confirmed COVID deaths. So true underestimate of the true mortality related to COVID. If you have a look at this diagram here, the map of the world, you will see the excess mortality due to COVID, and looking at mortality at a global level. And you can see that South Africa was not spared and probably had one of the highest case fatality rates. Certainly not low case fatality rate as we saw in the rest of Africa, but a lot of underreporting in Africa. So very hard to really quantify the mortality happening in Africa because excess deaths aren't really collected on our continent. But just to acknowledge that we probably had in the top 10, probably the top 5 highest case fatality rates in the world. If you have a look at our MRC burden of disease, this gets published every week, where we look at excess deaths, and we've been plotting excess deaths for many years now. You can see that we estimate that over 330,000 deaths have occurred during the pandemic, of which the burden was in 2021, where more than 200,000 South Africans died during 2021, outstripping HIV as the leading cause of death in 2021. In 2022, around just under 50,000 deaths have occurred. If you look at mortality in South Africa and look where most of the deaths occurred, you can see as compared to Western Cape, the Eastern Cape and Limpopo were almost 2 times and 1.7 times more likely. People from those provinces were more likely to die than from the Western Cape. And that if you use the first wave as a reference, you can see that the 4th wave, which was the Omicron wave, you were less likely to die as compared to what happened in wave 2 and wave 3. And then again, probably a proxy for socioeconomic status, if you compare people who were in the public sector as compared to the private sector, people in the public sector were 1.5 times more likely to die as compared to people in the private sector. Age, we know in South Africa, between 40 and 59 as compared to people under 12, almost 8 times, just over 8 times more likely to die. In the 60 to 79-year-old age group, 20 times more likely to die, and in the over 80, 35 times more likely to die. Men more likely to die than women, and Black South Africans more likely to die than white South Africans. So this shows the burden of COVID on our country, and obviously people with HIV, TB, and people with multimorbidity were also at more risk of dying than as compared to people who did not have these comorbidities. As we heard at a global level, there was always this discussion about preventing the loss of lives and the issue around preventing loss of livelihoods. And these trade-offs were played out in the public domain and at a global level, where we saw shutdowns, curfews, alcohol bans, and the inability of children to go to school. And as we juggled this trade-off while we waited for vaccines to arrive. And we saw at a global level huge loss of life prior to the vaccination rollout, and the healthcare workers bore the brunt of this at a global level and had to face wave after wave of COVID infections while they were waiting for vaccinations. We saw a lot of issues that our frontline healthcare workers faced, which exposed the lack of resilience in our health system. We saw at a global level a lack of direction and coordination. At a local level, we saw running out of oxygen, running out of beds, which necessitated the need for curfews to try and keep casualties open for COVID infections. We saw high workload, as I mentioned before, healthcare workers facing wave after wave and having to deal with both vaccinated and unvaccinated patients. At a global level, also the lack of PPE and often a discrepancy between nurses and doctors. We saw mental health problems emerge and post-traumatic stress disorder. a low social acceptance of healthcare workers who are working in the front line, and stigma, even to the case where healthcare workers, children who had to go to nursery school, there was a lot of fear that these children would bring COVID into the nursery school. All of us, and including healthcare workers, had to deal with bereavement, loss of peers, family and friends, and every one of us on this symposium have all experienced directly the loss of family members, our friends and our colleagues. And so this pandemic has touched all of us in a very, very intimate way. We saw a lack of resilience in the healthcare system at a global level, and this just shows you, if you look at India and South Africa and look at HIV and TB diagnosis, you can see that it's been very hard to get back to the 2019 levels. And yeah, you can see in India, TB diagnoses are not yet up, and in South Africa, how we struggled to get back to 2019 levels, both on diagnosing TB and managing CD4 and viral loads, which meant that people may not be getting their antiretroviral therapy. We saw food security and hunger during COVID. In South Africa, we saw child hunger, household hunger, and in the United States, we also saw food insecurity increasing. So even in high middle income countries, a lot of hunger were facing households and children. We also saw at a global level the impact that COVID-19 had on children. There are 616 million children that remain affected by school closures. In low and middle income country settings, there were learning losses to school closures that left up to 70% of 10-year-olds unable to read or understand a simple text, up from just over 50% in the pre-pandemic period. In Brazil, we saw 3 in 4 children in grade 2 were off track with reading, and across Brazil, 1 in 10 students who were between the 10 to 15-year-old age group reporting that they were not going to go back to school once school reopened. In South Africa, school children are between 75% and a full year behind where they should be, and some 400 to almost 500,000 students reported to drop out of school altogether between March 2020 and March 2021. So a huge impact on education and children at a global level. We saw loss of jobs, 3 million jobs lost in South Africa, mostly to women, and at a global level, terrible job losses. We also saw the misuse of public funds, both in South Africa and abroad, and this continues to scar South Africa's response to COVID-19 with the misuse of public funds that should have gone into PPE and other things. But there was hope right from the beginning of the pandemic, and that's what the hope was a vaccine. And the experience in SARS-CoV-1 and MERS outbreaks helped bring a substantial amount of work in the area of pathogen-specific vaccine development. And places like the Vaccine Research Center and other centers had a lot of experience in these outbreaks. And so when the Wuhan coronavirus was first identified, this led to immediate work on the concept of a vaccine. And there were decisions made at global level with existing pandemic preparedness programs for discussions and actions. And we saw the BARDA program and Operation Warp Speed that drove the vaccine development program in the US and in other parts of the world. And if it wasn't for the work done by Barney Graham on RSV, they extended to MERS and human coronaviruses, and who found the who demonstrated that the pre-fusion form of the spike protein elicited the best neutralizing antibodies. And these two protein substitutes dramatically increased the expression and stability. And these were used in most of the Operation Warp Speed vaccine program. And so there was a similar immunogen put into the mRNA products and into the Ad26 products. And yeah, these are the vaccines that at a global level got a lot of attention. The mRNA, and fairly new platform, and we saw the work from Moderna and Pfizer and BioNTech, and then the adenovirus work with AstraZeneca with the ChAdOx, and the A26 with Johnson & Johnson, and then some further work with recombinant protein and adjuvants with the work from Novavax, GSK and Sanofi. And this was an important thing to do at a global level, was to have an approach to developing a vaccine that was cohesive and could lead to a rapid take-up and assessment. And the Operation Warp Speed clinical trials program, which I was involved in, looked at harmonizing the efficacy studies. So taking all the platforms and making sure that we were collaborating at a clinical trial site, that there were harmonized endpoint data collection, that we used common labs, that the correlates of protection were used within and across protocols. And we also had a common DSMB, so that this common DSMB was looking at all of these programs and looking at all the endpoints and being able to make a call based on their collective experience from all these. So this helps speed up the clinical development of vaccines. And here's a good example of how fast the vaccine development happened. When the virus was first isolated in early January, at the time the clinical trials were started in early April, late March, and then the scale up to the phase 3 studies, and knowing in November that the mRNA vaccines were working, and on the 27th of January 2021, knowing that the single-dose A26 vaccine was working. And this was possible because there was a lot of work done in HIV that helped the COVID vaccine development. We were able to harness the HIV vaccine trials network, the HIV prevention trials network, the adult therapeutic trials network, and IDCRC, and all of this helped work at a global level to make sure we could do these vaccines. And this just shows you the vaccine trial sites that we had for these programs. As you can see, that South Africa was heavily involved in these trials, and that we had identified around 32 clinical trial sites that could rapidly execute this vaccine work. And these sites were critical for our ability to roll out our Sisonke 500,000 trial that we did when our vaccine program faltered. Then we saw, as I've mentioned before, the efficacy results that started rolling in. First of all, the mRNA from Pfizer, then the mRNA from Moderna, and then the single-dose emergency response with the A26 vaccine. And this was a very time having the A26 vaccine work done in South Africa as in the phase 3 allowed us to be able to make a call that this vaccine was effective against the beta variant that was circulating in South Africa, and was one of the scientific reasons that we went and rolled out the A26, because we had data that it worked in South Africa. And we saw that there were benefits of vaccination. There were the private benefits that reduced our risk of dying or being hospitalized, the public health benefits to reduce the burden on the health system, the economic benefits keeping people in jobs, social benefits to protect others, and there was an acceptable safety profile. There were some rare serious adverse events that were emerged after millions of people got vaccinated, and this was the thrombosis with thrombocytopenia syndrome, the TTS, after COVID after the A26 vaccine and the ChAdOx vaccine. There was myocarditis after the mRNA COVID vaccines, and then there was the Guillain-Barré syndrome, which was identified after the A26 vaccine programs. And this is just the amount. There are about 3 cases per million of TTS, around 8 cases per million of Guillain-Barré, and around 3.5 cases per million doses among adults. And this safety profile has emerged after seeing billions of vaccines being given, and there are no additional safety signals. And I think at a global level, with the billions of doses given, we're able to understand the safety profile of these vaccines much better than in the early days. And this just shows you the risks and benefits at every age group. For all the cases of GBS or TTS or myocarditis, you can prevent hospitalizations, ICUs, and deaths, and even in young age groups, and obviously more pronounced and profound in the older age groups, where for an 8 to 10 Guillain-Barré cases identified with a COVID vaccine with A26, you'd prevent almost 6,000 hospitalizations in women, 1,250 ICU admissions and 840 deaths. And similarly in men, it was even double, preventing almost 12,000 hospitalizations, over 3,000 deaths, over 3,000 ICU admissions and 2,300 deaths. So definitely a great risk-benefit ratio to justify the mass rollout of these vaccines. We also saw at a global level this unequal scramble for coronavirus vaccines. The US secured 800 million doses. So of at least 6 of the vaccines that were in development. The UK was the world's highest per capita buyer, with around 340 million dose purchases, which is about 5 doses per citizen. Other countries, other low middle income countries also got in and secured vaccines. So Brazil and Indonesia. The Serum Institute signed a license to produce a billion doses of the AstraZeneca study. And there were financial, but what we did see was that the financial deals were shrouded in secrecy, and some countries paid for the vaccines and funded the clinical development, and the cost was variable. And so there's a lack of information at a global level to understand the conditions attached to the funding and the purchasing. We saw, that a lot of countries who agreed to, who pre-ordered vaccines, and you see, as I mentioned before, the UK that purchased more vaccines at a per country level than any other country. And you can see the distribution of the products and the countries, with very few countries in Africa having pre-ordered any vaccines. At this moment in time, you can still see that there's a global inequity in vaccine coverage, and this is now no longer due to a lack of supply, but rather vaccine hesitancy, vaccine fatigue, and a feeling that where we are in the world, we no longer need or require ongoing vaccinations, and that we're in a stage of the pandemic that where some communities feel that it's hard to justify vaccine use. And so I'm going to, in the next part of my talk, just show you why vaccines are still important and why they still continue to have an importance in our lives. So looking at vaccine data, effectiveness data from South Africa, we were able to show with our Sasonke study that the vaccine worked in both the Beta and the Delta waves, and prevented both hospitalizations and deaths as compared to healthcare workers that weren't vaccinated. And you can see both in the Beta and the Delta period, we were able to demonstrate that the single dose of A26 was effective in preventing severe disease and death. You can see when just looking at the Omicron period, this became important, but also you can see looking at 2 doses of A26, we were able to secure another amount of vaccines, and another 250,000 healthcare workers were able to get a second dose of the vaccine. And you can see the effectiveness of the 2-dose regimen in the Omicron period. And this is the early Omicron period and the BA1, BA2 period. You see, comparing the 2 shots of A26 with 2 shots of Pfizer, you can see that both vaccines were highly effective in reducing hospital admission and ICU. So still in the Omicron period, evidence that these vaccines were working. And then just recently, we've published data on looking at the vaccine effectiveness of 2 doses versus 3 doses in both the BA1, BA2 Omicron period and the BA4, BA5 Omicron period, and showing that you can get vaccine effectiveness up to your prior levels, but there is waning of immunity, and that we probably need frequent boosting from 4 months onwards, according to the data we're seeing here in South Africa and at a global level. Is there still a benefit to vaccinate in this period that we see, particularly in South Africa with our high rates of hybrid immunity? And so what is hybrid immunity? Hybrid immunity is immunity that we get from repeated exposure to the immunogen, either vaccination and natural infection, or natural infection and vaccination, or just repeated infections in various waves that give us this hybrid immunity. And yeah, you can see that at a global level, although there is under testing, we're seeing that there are parts of the world that are still having substantial COVID transmission. And this is obviously of ongoing concern. And if you look at South Africa, you can see we've emerged out of our BA4, BA5 period, but we still have low levels of volatility in certain parts of the country, as evidenced from our wastewater surveillance and from watching the CT thresholds from tests that are done, looking at trying to see whether the community viral load is going up or down. So still ongoing transmission in South Africa. And this just shows you the high seroprevalence that we have of SARS-CoV-2 in South Africa. And we now estimate that probably more than 95% of people in South Africa have been exposed to SARS-CoV-2 in the various waves that we've seen in South Africa. And this just shows you the age range and the various waves of doing these surveys, how the seroprevalence increased both in an urban and rural community. A nice study done by Heather Zaar, who followed up women in South Africa, mothers in South Africa, and looked at looked at mothers who had got one dose of a vaccine and hadn't had previous infection, compared to a woman who had one dose of the vaccine who had previous infection, and women who had 2 doses of a vaccine with no prior infection, and who had 2 doses of vaccine with previous infection. You can see that how wonderful hybrid immunity works, that it augments your immune response, and this continued exposure to the immunogen helps expand our immune response and helps avert our waning immunity, either from natural infection or from vaccine-induced immunity. This slide shows the continued benefit of vaccination in all the age groups as compared to unvaccinated adults, particularly over 65. The hospital admission was more than 5 times higher in unvaccinated adults, and you can see in and almost more than 7 times in the ages of 50 to 64. So still showing tremendous benefits of vaccination in all the age groups as compared to unvaccinated individuals. What is the end game for COVID? And I guess the end game is related to viral evolution, which is tracked at a global level by us being able to do analytics and uploading the data to DISAID. And yeah, you can see that we are in an Omicron period, but an Omicron period with sublineages. And yeah, you can this is data from today that just shows you the distribution of the sublineages in the Omicron area, and the evolution over time from January this year. So it's a very nice global picture of what's happening. And this just shows you the evolution in spike in the Omicron period, and you can see how far the relatedness between Omicron and other variants, and you can see how far the evolution has occurred in the Omicron period. We are fortunate in South Africa to have a network for genomic surveillance, and this surveillance occurs and a collaboration between both academic and NHLS at a country level to try and understand our local sequencing and surveillance and evolution of the virus. And yeah, you can see how the virus has evolved in looking at various variants of concern and variants of interest from August to October, where now we're in a period where BA4, BA5 is predominant, and how it's evolved since the time in August. So it's an important piece of work for us to keep track on to see how the virus is evolving in South Africa. There's still increase in hospitalizations and cases at a global level, and this just shows data from this week that shows that there's still increasing cases in Singapore, Germany, France, Denmark, and the United Kingdom. So still ongoing transmission at a global level, and also ongoing weekly hospital admissions at a global level. We know that Germany went through a terrible time in the last few weeks, and that hospitalization rates are increasing in other parts of the world, showing that COVID-19 is still a big problem at a global level. What is the end game? Will we be able to eradicate this virus? And it's probably unlikely. It's unlikely that we'll be able to reduce global the disease prevalence to zero. Both our natural immunity and our vaccine-induced immunity are not effective enough and not long-lasting enough to prevent secondary transmission and reinfection. So unlikely with the current tools and the waning of both natural and vaccine-induced immunity that we're able to eradicate. But we'll be able to eliminate SARS-CoV-2 in certain parts of the world, and from time to time we do see regional reductions of disease prevalence to zero, and we saw that in New Zealand, but it rapidly changed, and so unlikely that we're at a phase where we can have elimination. We appear to be at a cohabitation phase where this hybrid immunity prevents severe disease, but transmission and reinfection continues to occur. And the fear in this cohabitation period is that we know that this decoupling of cases and deaths and hospitalizations may not continue, and that as the virus evolves, we may not see this decoupling, particularly if there is waning immunity and not regular boosting. And then obviously, could we be where we probably are in South Africa, the steady state that we see post-Omicron BA4, BA5, where we have this moderate level of endemicity that we see that we seem to be seeing in South Africa. So what do we do about future work in surveillance, and how do we prepare for pathogen X, and will we be ready the next time for a new pathogen that arises? And this is why it's important for us to continue to do the surveillance that we do, both in the wastewater and in hospitals. That whenever there is the emergence of a new virus or pathogen, that there is always an independent and transparent investigation into the origin, which will help us understand what's happening in terms of the reservoir of the host, and how the zoonotic the process of the zoonotic disease getting into humans. The health system is important. We've seen that we have to have good health system resilience, and we have to protect our healthcare workers. We need to make sure that our mitigation strategies in the future don't impact on our economic activities or our schooling. And we also have to work at preventing corruption. Vaccine development and access to manufacturing capabilities is a must in Africa, and we need to invest in vaccine manufacturing. And we also have to pay attention to human well-being and mental health and support. And this is where local vaccine manufacturing is important. We've seen both BioVac and Aspen proliferate the ability to do tech transfer and help fill and finish. And we also are very lucky in South Africa to be part of an mRNA tech transfer hub, where we've with Afrigen are making mRNA. With BioVac, we'll be able to scale it up, and the MRC is involved in the clinical evaluation. And hopefully we can use this as a template for future pandemics, as well as for other pathogens like TB and HIV. So this is a very important public-private partnership that will hopefully build innovation, build capacity development, allow us to rapidly respond to future pandemics, and train a workforce that will be able to respond to in a workforce in biologics. So a very important thing to do, and hopefully this will bear a lot of fruit in South Africa. So I'm going to end by saying that the future needs vaccines. We know from the data that I've showed you and from data from all over the world that booster vaccines are still likely to be critical for the waning immunity that we see. Hopefully, we will see technologies that will cause vaccines to have a longer lasting immunity. Unfortunately, adult immunization is upon us, and we will have to embrace this as we depoliticize vaccination and science. We in medicine, we have to learn to be trusted sources of scientific information. We need to learn to hone our communication skills, counteract disinformation, call out colleagues who promulgate and likely profit from this, and spend more time being seen as trusted sources of scientific information, and also trusted sources of tackling and debunking false information. So I think in terms of going forward, we have to create trust in modern medicine, and also learn how to work with communities, particularly in this period of time where we have a lot of vaccine hesitancy and vaccine fatigue. The importance of continuing to encourage communities to vaccinate and understand what are the drivers against vaccination and what are the fears that people have at a community level around vaccination. And so again, what the pandemic has taught us is that science knows no country, because knowledge belongs to humanity and is a torch which will continue to illuminate the world. And definitely COVID-19 has taught us this. So I'm going to stop sharing now. And I guess this is the time I'll answer questions. Are there 4 questions in here?
Yeah.
Who's going to, Stephanie, are you going to
it's Stephanie Burton here, yes, and may I just say good evening to everybody, and apologies for the fact that I wasn't here at the beginning of your talk, Glenda. I'm here now, and I'm really very pleased that we've been able to, I caught most of what you had, and I'm really pleased we've been able to hear your expert views. There are a few questions in the chat box. I'm not sure if you are able to see them, but let me relay those as a start. The first 2 are actually about booster vaccinations, and your comments on waning immunity, and in particular the question about whether people who are over 60 or 65 should be getting another booster, or a second one, or a third one, and would that be advisable? So that's I think the first important question, if you'd like to answer that one.
Okay, so based on the data that we have from South Africa, we do believe that people should get booster shots at least over 60 every 6 months, and and the data that we see is that we probably from our point of view, we would recommend it from 4 months since your last vaccination or exposure to a natural infection. So we do recommend that at least every 6 months, people over 60 should get a vaccination. And obviously, I would time it with if you've had a reinfection, and space it out so that you can that you can address the waning immunity, and hopefully the exposure to natural infection together with your booster will help hopefully lead to a more mature immune response. And we are looking at some data that hopefully we'll be able to share next year, looking at the maturation of the immune system with this ongoing exposure to immunogens, be it natural infection and vaccine-induced infection. Vaccine-induced immunity.
Can I just add a question to that myself, and that is, can we just walk in and get another booster? Is there still some regulation around who can go for boosters? So
people who are immunocompromised and people who are over 60 can go for boosters, but at this stage, it seems from what I'm hearing that as long as you know where to go, and there is a if you should, people should already be looking at their third vaccine, and definitely people over 60 should have had at least their third vaccine, and people over 50 should be now thinking about getting their third vaccine if they haven't got it. So given the poor uptake, I think at this stage we're seeing about 8,000 vaccines being given on a daily basis in South Africa, and that's down from very high rates that we saw during the vaccine rollout. Is that at a local level, it is likely that you can get your third or your fourth vaccine and not be gated from it.
Thank you. Yeah. So the next question in the chat is about, it seems that the new variants have become less lethal, less dramatic, perhaps. Is there a prediction that in future we can expect that the infections will be less dangerous, perhaps?
Well, we hope so. I mean, so the experience with Omicron in South Africa and elsewhere has been a little bit different. So we definitely saw the decoupling of cases from hospitalizations and deaths. Other countries where maybe there wasn't so much prior exposure to SARS-CoV-2 due to natural infection, the decoupling was not as dramatic as we saw in South Africa, and obviously was fueled by the lack of hybrid immunity. So I think South Africa led the world with its hybrid immunity and demonstrated this decoupling, and we attribute this decoupling to the hybrid immunity. And so in other parts of the world, the US still had a high rate of hospitalizations and deaths during Omicron, and continue to see that. And that's probably a combination of not having enough exposure to an immunogen, either vaccine or natural infection, prior to the exposure to Omicron.
So there's another question, and when I thought to add to it, there's the question of countries that slowed or halted the cases by just preventing travel, closing their doors. But they were some of them quite slow to move with vaccination, like New Zealand, for example. And I just saw from your map the Australia situation, where they still have quite high levels of infection. How does that affect travel? So, for example, would it be a bad idea to visit Australia for us at the moment? Are we likely to bring back infection into the country? Is there any kind of restriction that we should be considering?
Well, I think it probably, so what you see what you saw in New Zealand, is true, is that they were at some stage able to keep their island, seroprevalence down to 0, but it's hard to maintain. And then in Australia, we had very high rates of vaccination, but also very, very little prior exposure to SARS-CoV-2. So what we do see, just from our experience, is that it'll depend on how often you've been vaccinated and how often you've got other infections, but it doesn't mean you might not escape a new variant that is in that country. I mean, I've seen healthcare workers who've traveled for conferences, who had Omicron in December, BA1, BA2, who got Omicron BA4, BA5 in Canada. So I think that you will continue to see infections, and you will continue to be exposed, and depending on your natural immunity, and I guess what the variant is, it might escape the neutralizing antibodies, particularly if there's waning immunity. So you are going to be susceptible. So I think you have to make that call, and maybe sometimes things like non-pharmaceutical interventions like masks, making sure that you are not in overcrowded areas. Good ventilation may also help minimize exposure in other parts of the world.
Oh, good. And if we go to the other parts of the world, we even if we are immune ourselves, we chance bringing back the new variants into
So
the
we did
country?
see, so we do see the movement, and we do see definitely movement and transmission. So that will, whether people are coming to us or we're going to them, as long as there's movement, global movement, and waning immunity, we will see the spread of variants at a global level. And hopefully, I mean, as we've seen, Omicron has become the dominant, and its sublineages have become the dominant variant circulating at the moment. And just in terms of the question about will we continue to see this, it's hard to predict, given how far Omicron diverged from the other variants. It's hard to predict what the next variant will be, and whether there will still be this decoupling from cases from deaths.
Sure, thank you. Some further questions. There's one which is a very different question, but how significant was South Africa's role in vaccine development in the very early stages?
So when in the very early stages, we realized that we didn't have enough money to make our own vaccine and develop, so we quickly scientists partnered with people all over the world. So because of my HIV vaccine experience, I partnered with the CoVPN and Operation Warp Speed, and from March we were on course planning these studies, and Shabir Mahdi collaborated with Novavax and Chadox, and so I think our collaboration and our global networks enabled us to work in the clinical development and the laboratory understanding of it. But it showed us our need to develop vaccine discovery capability. And hopefully now with this mRNA hub and a resurgence of people seeing the need to develop this capability, we hopefully will see a proliferation of vaccine discovery happening in South Africa. And we're seeing it now in TB, where with using the mRNA platform, we have very exciting immunogens that we hope to evaluate in South Africa. So hopefully, so we were very good at the clinical development phase and working with, and our lab scientists were very good also in identifying the neutralization and worked at a global level. But we never had the money or the kind of vaccine discovery capability to be able to work like the Vaccine Research Center in the United States, and the background, the experience that they had on MERS and SARS-CoV-1 and coronaviruses. We didn't have that experience, and so I think it's important to invest in that working with viruses and being able to be involved in vaccine discovery to a much greater extent than we have in the past.
Thank you. Next question is again different. A question about the early demographic forecasts of the impact of COVID seemed greatly exaggerated. And the question is, will there be a reckoning, and who will do it? So will we eventually know the real impact of the pandemic in terms of
if you look at
demographics?
If you look at the so in terms of, are you referring to excess deaths, I guess? The early demographic forecast. So I mean, I think the only way you can measure the impact of the pandemic at a global level is to look at excess deaths. And what we did find out with excess deaths, that not all countries are capable of particularly in Africa, of measuring excess deaths. And even some more developed countries were not good at it either. And so we probably have underestimated, in my opinion, deaths and mortality from COVID-19 based on our lack of surveillance and good health systems. So in terms of a reckoning, what we have to do is make sure we have robust surveillance systems in place to be able to quantify the impact of a pathogen on hospitalization, death, and that. So I don't know if we can say now that what is greatly exaggerated, for me, 20 million deaths is a huge burden. So I don't know, what greatly exaggerated would mean. At the moment, all we're looking at is the excess deaths, and
Sure.
an evaluation of that. Certainly, the mitigation strategies impacted too our ability to affected malnutrition, child survival, affected antenatal care, it affected immunization strategies, it affected schooling, and affected the economy and job losses. And I guess for me, the reckoning should be, did our mitigation strategies, were they justified?
Yeah, sure. So then there's a couple of questions which relate or coordinate perhaps a little bit with climate change. The question about the collaborative international response to the pandemic, perhaps helping to energize the international response to global climate change. And then a question about whether there were environmental benefits of the COVID pandemic. There's an example of the extent of bushmeat trade, but the relationship between the pandemic and climate change and environmental benefits?
Well, I think that we understand that climate change will impact on things like so I definitely think, so let me rephrase it. I definitely think there's a relationship between climate change and future pathogens and and I think we have to pay attention to that. Climate change is important, and I think the pandemic has highlighted our vulnerability, and if we don't work on climate change, we're going to have more and more pandemics. So hopefully there won't be fatigue after this. And been watching what's happening in Egypt around climate, and hopefully this collaboration, international collaboration, and our worry about climate and health will continue to energize that research on and demonstration of the global climate changes that are happening, and that there probably were, in terms of the environmental benefits, I think it highlighted, the kind of fur farming, the trade with exotic animals. So I think that those were definitely, there were definitely environmental benefits where, the identification of even in, I think, Sweden, that there's these farms where for farriers where animals are bred for mink farms. And so I think those, and then we saw in China how they curtailed all that exotic trading of exotic animals. So I think it's important. So I do hope that we can continue to work on that and control things more effectively.
Thank you. And then there's two questions which are sort of the opposite sides of a coin. One of them is the question of countries with a zero COVID policy. How do we see that panning out? And then opposite to that, countries like Sweden, which initially imposed no curbs at all on public movement in order to achieve fast herd immunity. And was that a good strategy? So which of those two strategies look like they worked or didn't, and were they good or bad, or what will their impact be?
I mean, I think the most important thing about the pandemic was to make sure that there was good ventilation, that we understood, that there was that we didn't congregate in crowded areas, and that we tried to minimize transmission by wearing masks. So, but that obviously is not sustainable, and I guess from time to time people do heighten their responses when they are exposed. Sweden, I guess South Africa is a good example of what happened. So I guess we were like Sweden. So even though we locked down, in overcrowded areas and people using public transport, we were never ever going to be in a situation like Australia, where there was a very little very little people exposed to COVID over time. And so I guess South Africa got the worst of both worlds. We, by having overcrowded situations and using public transport, we did have ongoing exposure to SARS-CoV-2 over time. And then with a moderate vaccine coverage, we were able to see this decoupling. Certainly, you need the combination of natural infection and vaccination to manage SARS-CoV-2 going forward. And I think the mitigation strategies were not helpful to both society and certainly in South Africa. Besides the only thing that helped us was the curfew and the alcohol banning to open up beds so that there weren't accidents and interpersonal violence and injury, and it allowed us to divert the emergency room beds to COVID. So that those were the benefits of curfew and controlling alcohol use. Wasn't for COVID itself, but it was to help the health system respond to the onslaught of COVID. So I think that going forward, we have to understand our community, our country, and certainly the mitigation strategies that we put in place did not help people not get COVID. And we saw high rates of infection and reinfection, which is proof that the mitigation didn't help and caused a lot of harm.
Sure. Perhaps continuing that line, and I know we're just about out of time, but there's just a question about new pathogens causing high mortality and whether over time we can speculate on the future evolution of new variants and what impact they might have. Can we speculate, or do we have to wait and see?
Well, I think you have to. I guess we have to watch how, and I think it's a combination of your immune response and how the virus evades neutralization, and how the virus evades the immune system to survive. And hopefully, I err on the side that hopefully we will be in a situation like we are with Omicron, where we can manage the severe disease and death, and not be in a situation where our immunity has waned so much that a new variant comes along and we haven't got enough. Our immunity has waned so much, both either from natural infection or vaccine-induced infection, that we have severe outcomes like hospitalization and death. So I think it's about the waning immunity that worries me, and how the virus will evolve when there is waning immunity. Yeah. So we have to keep on watching the viral evolution, and hopefully that this Omicron sublineage area that we're seeing will continue and persist, and we will see this kind of living with COVID and with some grumbling and pockets of hospitalization and deaths, depending on where you are in the country or in the world.
Thank you. And Glenda, one last question, which is again a little different, but before we end, and I think it's an interesting one, is a request to comment on the World Health Organization's program of infodemics to deal with misinformation. Perhaps the question is really, how effective is that, and what else can we do about misinformation?
So I think that we need a lot more work in this area. So we've ignored the social science, behavioral science, anthropology, and true understanding of human health in its entire form. And so I think we need to really look at this in a way that will understand how to deal with misinformation and understand what the drivers are. So too little work has been done on this. We focus mostly on the biological interventions and biological tools without actually understanding society or human beings.
Thank you. Glenda Gray, thank you for an absolutely amazing presentation and for answering these very diverse questions. We really appreciate that you've spent time with us, and you can see from the number of people who have attended this meeting and the number of questions, just how much I think our audience have appreciated your presentation this evening, and as I say, for responding to all of those questions. So let me conclude by saying, on behalf of the Royal Society, thank you so much for the very informative information, the talk, and we look forward to hearing again, I hope. As things progress, we'll invite you back, I hope, to come and give us further updates later. But for this evening, let me say thank you to you, and thank you also to everybody who has participated this evening and who has listened. And also thank you finally to Bert Klimperman, who covered for me at the beginning of this evening. So thank you, Glenda, and good evening to everybody, and have a good rest of your evening.
Thanks.
Thank you.
Thank you.
Thank you.